Good afternoon. Dr. Dale Bratzler. I'm the Chief COVID Officer for the University of Oklahoma and also the Enterprise Chief Quality Officer for OU Medicine. I'm going to start off with just a very brief kind of update of where we're at right now in the state of Oklahoma with respect to COVID-19. This has been a challenging week for our state. Within the past 7 days, we've seen 5,000 newly confirmed cases in 1 week. Compare that to when we first started this pandemic. It took us more than 2 months to get to 5,000 confirmed cases. So what that highlights is that we're seeing real rapid growth of the cases in Oklahoma. We're right around 24,000 cases right now in the state with 699 new cases reported today. The number that I watch very carefully is the average number of new cases each day in Oklahoma right now. We're at 700 or so cases every single day that are being confirmed in Oklahoma. Hospitalizations hit a peak this past week at 638, but most of those were people who had confirmed COVID-19, patients who were in the intensive, about half of those patients were in the intensive care unit, and sadly today we saw another, I think, increase in the number of deaths. We saw 7 new deaths reported today, and I'll just highlight that 2 of them were in that 36 to 49-year-old age group, so they were younger than we've typically seen at the start of this pandemic. So we're seeing almost unmitigated spread of the virus. In Oklahoma still, it's the 18 to 35-year-olds that represent the biggest group of people that are getting the infection right now. But we've been watching carefully the age group demographic, and we're seeing that we're starting to see more cases now in the 65 and older age group. And those are the people who are really at risk of severe complications of this particular disease, much more likely to be hospitalized. And in Oklahoma, 80% of the deaths have occurred in people who are above the age of 65.
So Maureen with KTUL in Tulsa, kind of to expand on that, she said, you know, it has been a big week. Do you feel like this was an anomaly, or is this pretty much what we are going to be seeing for the weeks to come?
Yeah, so, you know, we saw 2 days with really big peaks, 993 cases one day and 1,075 cases one day. And Tuesday was the day we hit 993, and again, I think all of us have seen the Tuesdays are a big day oftentimes because a lot of lab work comes into the state health department over the weekend, and then it gets incorporated into the reports on Tuesday. So I wasn't too surprised with that number. The 1075 on Wednesday was a very large number. I don't know if there was some catch-up that was still being happening, but even without that, we had 700 new cases today. So that's right about our average right now. 700 new cases are being confirmed in Oklahoma each day, and that's a lot of cases. Remember, there was a time not that long ago that we were in the 60 to 70 new cases on average per day.
Jeff at KOCO wants to talk a little bit about the beds, the hospital bed situation. He said, it appears that we have sufficient surge capacity in ICU beds, but we're hearing that ERs are on constant divert and sending patients to rural hospitals because the ERs are overrun with COVID, including those seeking tests who don't need to be there. Can you kind of clear that up a little bit?
Well, yeah, so the question is about hospital capacity, surge capacity, and emergency rooms. So first, I would strongly recommend if you think you need a COVID test, don't go to the emergency room. There are better places to go. There are numerous sites that you can get at urgent care centers that are out there. So please don't go to the emergency room if you just think you need a test for COVID-19. I don't think there's a whole lot of cases being transferred to rural hospitals right now because the ERs are overwhelmed. I will tell you that I disagree with one statement, and that is that hospital capacity is getting stretched. In Oklahoma City in particular, ICU beds are becoming a premium, and I know that Tulsa has seen a substantial increase in the number of people that are in the hospital and in their intensive care units. So I would argue that we're actually starting to strain hospital capacity at this point. And sometimes it's not about how many licensed beds you have, it's how many nursing staff and others you have to actually staff those beds. So I think people have been led down the pathway of thinking that we have lots of surge capacity. We have lots of PPE now, we have plenty of ventilators, we're starting to run out of ICU beds, and our hospital beds are much fuller than they were. Remember, right now, we're doing elective operations, We have cancer patients in the hospital. We've returned back to usual operations of our health system. I was just commenting, I don't know how many helicopters I saw land at our hospital yesterday. Traumas are still coming in, cancer patients. And so, the majority of patients that are in the hospital in the intensive care unit are not COVID patients, and there isn't that capacity that we had in the past to take care of more. So we're starting to see a real strain on hospital capacity.
So he's also wanting to know, what is the process then if somebody came in, and I assume that he means with COVID, then how do we determine if we have enough beds that we should keep that person? Obviously it has to do with the health of the patient, the level of the disease, I suppose.
Yeah, so I don't know that we've had to transfer any patients at this point, but I know of transfers that have occurred in the Tulsa region. So basically, if a patient comes in, if the diagnosis of COVID-19 is known, obviously the patient is immediately put into complete isolation and separated from all of the other patients that are in the emergency room. And then we have special units that we keep those patients in, cohorted to protect other patients in our health system, like cancer patients or others that we don't want exposed to this particular virus. If our hospital beds fill up, then we have overflow capacity in our emergency department and a couple of other places. But I think a lot of hospitals in the Oklahoma City region now are starting to see that, and I know it's happened in Tulsa. Take Integris, they had to go ahead and reopen the Deaconess facility to start using that for some of their overflow of patients with COVID-19.
So that answers somebody else's questions pretty much. Cassandra at K4 wanted to know if you could talk about the percentage of positives that are coming from healthcare workers. What does that mean for hospitals and ICUs that are filling up because there's a bed? Her point being, what about staffing?
Yeah, so in Oklahoma, the last epidemiology report from the state health department showed that 8% of the confirmed cases in Oklahoma were healthcare workers. I can tell you that on our campus, and I think on a lot of campuses, the fact that healthcare workers do get very tightly exposed to patients with COVID-19, that their risk of getting infected is greater. And our employees, just like employees of any industry, are out in public life when they're not here working and can get infected in the public areas also. So I think all the systems are worried about the number of healthcare workers that are being isolated, that can't come to work anymore. So we have a number of people that are in isolation, as do all health systems, and that will strain capacity for the healthcare workers to actually take care of these patients if they're in the hospital.
Said that Chuck Spicer talked about how ICUs are full of not only COVID-19 beds, but there's also other very sick patients. So that affects the bed capacity as well. So is this something we're seeing?
Yeah, so I don't remember the exact number, but I saw the statistics in the Oklahoma City metro that about 75% of the ICU beds are filled with people who don't have COVID-19. They're the patient that's had a stroke, or the patient that's had a heart attack, or the trauma cases that come in, the motor vehicle accidents, the severe injuries, or the cancer patients that are very ill. Those are the majority of patients that are filling ICUs today, but what we're seeing is the rest of that capacity now is being filled up very quickly with COVID-19 patients, and so finding alternative settings of care is going to be important for those patients. We tend to not admit a COVID-19 patient to the hospital unless they need real support, like oxygen support, medications, or other things. Because remember, most patients with COVID-19 do recover. They may be very miserable for a while, but they do recover in the home setting. But those people that get sick enough to be in the hospital, they tend to be very ill, and they're starting to fill up the remaining ICU beds.
Erica Rankin at Channel 9 wanted to talk a little bit about research, specifically the vaccine that you were mentioning earlier, that there's some phase 3 trials have started, I guess.
Yeah, so I'm going to talk about research in two different ways. One is vaccines. There are a couple of vaccines now that are in phase 3 clinical trials. The news this week was Moderna, their messenger RNA vaccine, which takes a fragment of the virus, injects it into the body, makes the body make the spike protein, protein that you see on the outside edge of the virus, and then your body develops antibodies against it. And so in the initial study that was reported in the New England Journal of Medicine this week, 45 patients, very small, but was safe and was effective at generating what we call neutralizing antibodies, which are the antibodies that will stop the spread of the virus and block it from causing the infection. So that's the good news. 2 different vaccines that are starting phase 3 clinical trials, and everybody's hopeful that certainly by early 2021 that we may start seeing vaccine hitting the market. The other areas of research I think have impacted mortality. So there is good news. We now have 3 drugs, and there may be others, but 3 that I'm aware of that have been shown to reduce the mortality from COVID-19, particularly when those patients do get very ill, they're in the ICU or on the ventilator. One's a common medication we've had forever, dexamethasone, a steroid, very effective. It's substantially, I think, about a 30% reduction in mortality when patients were very ill on the ventilator in the intensive care unit. Another one is remdesivir. Remdesivir is a medication that was originally developed an antiviral and used partially for trials for Ebola, but it has shortened hospital stay substantially in these patients. Its impact on mortality is not exactly clear yet. It looked like it was reducing mortality, but it wasn't a big enough study. And then one of the monoclonal antibody drugs that are often used in rheumatoid arthritis patients that actually blocks that immune response that seems to characterize those patients who get really sick, develop the pneumonia, have this inflammatory response. That monoclonal antibody drug actually can substantially reduce that, and in the early trials has shown a reduction in mortality. So that's the good news, and I think it accounts in part for the reason that the death rate from this virus has not gone up as rapidly as we might have expected.
So let's talk about masks. Kaylee at Channel 9 was wondering if you could just go over again how effective they are, and what do you think about mandates?
Yeah, so this virus, again, we're seeing 700 new cases a day in Oklahoma. The virus is spreading through the population quite rapidly at this point. There is no vaccine yet. There is no medication that's been shown to prevent this particular virus. There was a study today that came out and said vitamin C and zinc didn't help. So in the absence of anything to prevent the spread of the virus and no vaccine, we're left with public health measures. So the 3 that we're promoting the most: physical distancing, hand hygiene, and wearing a mask. And wearing a mask have been shown to be very effective at preventing person-to-person transmission of the virus. If you look at the studies that have been published, the range has been anywhere from 70 to 85% reduction in transmission of the virus from person to person. In the medical setting, an article came out this week that showed that if you had universal masking like we do at OU, where both patients and staff are wearing a mask, they saw dramatic reductions in the number of healthcare workers who became infected with the virus. So the data is very, very consistent now that wearing a mask will reduce the transmission of this virus from one person to another, and that's why we've been working with city councils and mayors to put masking ordinances into place, because we know we don't have any other options right now to slow down the spread of this virus.
So Jamie at KOCO was also just asking if masking up was truly the best defense. Do we still need to take extra caution to stay inside?
Well, so I would generally say try to avoid public or crowded places. No mask is perfect. None of them prevent 100% of infection. So if you get into a crowded circumstance around a lot of other people, you do put yourself at increased risk. So I think going outdoors is safer than indoors, but if you're going out to crowded places like restaurants, bars, or going to events where there are a lot of people inside, you increase your risk of potentially getting infected. So as I mentioned before, if you combine physical distancing with wearing a mask, you can substantially reduce the transmission of this virus.
And are there any patient populations or healthcare reasons that somebody shouldn't or can't wear a mask?
You know, I get that question often, and I've talked to some of our pulmonary doctors and others. There are not many reasons that a patient can't wear a mask. We even had patients with emphysema who are on oxygen, so they're on their oxygen in their nose, but they put a mask over it. So most of the time, there are a few people that don't tolerate it very well. If an asthmatic is having a severe attack, then they might not tolerate, because wearing a mask does slow down the airflow just a little bit. But most asthmatics, I would strongly recommend that they wear a mask so that they can prevent themselves from getting the virus, because if they get the virus, they're not going to do as well as a person who's healthy. So there aren't many medical conditions that just absolutely obviate the ability to wear a mask.
Okay. Sherry with the Tahlequah Daily Press was wanting to talk about the differences between COVID, influenza, and the cold even, and how do the numbers of annual flu cases compare to what we're seeing now?
Yeah, so it's a very, very common question. So let's take the cold first. So almost all of the people that are listening today have been infected with a coronavirus at some point in their life. They're very common. There are many of them out there. They cause things like the common cold, upper respiratory infections that typically peak in December, January, February. So coronaviruses are quite common. Influenza is a respiratory virus, spread very similar to COVID-19, comes from droplets that come out of your mouth. That's the most common way that people get influenza. It varies each year in terms of both its mortality, its infectiousness. We develop a new vaccine every year, and that varies in its effectiveness from being, not so great to really good, depending on the match for the virus each year. Influenza definitely causes deaths. A lot of people like to compare the estimated influenza death rate to the known COVID confirmed death rate, and that's not a good apples to apples comparison. I talk about it often in my Facebook post about the fact that in Oklahoma this year, 2019 to 2020 flu season, there were only 85 confirmed influenza deaths in the state. We've had more than 400 deaths with COVID-19 just since March. And 135, I looked today, I think 138,000 deaths in the United States from COVID-19. The news this morning was reporting that there are 1,000 deaths every day from COVID-19 right now in the United States. And so the comparison I always highlight for people is, when's the last time you remember hospitals commissioning refrigerated trucks to hold bodies during flu season? I just don't remember that. But that's what's happening in these hot spots around the country with COVID-19.
Can you explain what even herd immunity even means?
Yeah, herd immunity. So herd immunity is this concept that if enough people in the population are immune to the disease, there's two ways to become immune. One is to get the infection and develop your own antibodies and immunity. The other way is to get a vaccine. But when enough people in the population develop that immunity, then it makes it very hard for the virus to spread from person to person, because if you get infected but I'm already immune, you can't spread it to me. So it really slows down the spread of the disease. Now, for some diseases that are highly infectious, you have to have a lot of people immune to stop it. Measles is the classic example, where you need more than 90% of the people to be immune to stop it from spreading. COVID-19, we don't know what that number is going to be. Most people are estimating around 70% or so of the people need to be immune. That's 2.8 million Oklahomans. And right now, even estimating that there are 10 times more people that have been infected with COVID-19 than the confirmed cases, that would be about 240,000 Oklahomans that may have been infected with this virus. So we're not even close to herd immunity at this point. And if we get there through infection, a whole lot of people will die in the process.
Okay, Sherry at Tahlequah Daily Press wanted to talk about schools a little bit, because I guess Tahlequah is getting ready to send 1,300 people back to one school building. So she's just concerned about how that kind of goes against the state's guidelines for reopening and things like that. And
Yeah, you know, I did a press event last night with Joy Hoffmeister, and we talked a lot about how do you keep schools safe. Obviously, there are certain things that we're doing. You know, she was even asked during the presentation, would you send your kids to school? And she said, only if they required a mask. This is the state superintendent basically saying, I'll only send my kids if they require a mask. So that was the first thing. And then secondly, any way we can do physical distancing will be important. So what I think a lot of school districts are doing are trying to physically distance people in the classroom, wearing masks, maybe staggering some of the students, using online education for at least some students or part of the students or part of the day to separate people, lots of disinfection and sanitizing things in the school system, avoiding some of the buffets and going to more, we'll hand you your food and things to keep people from directly interacting with each other. It's you know, something I think it's going to be tough, and we'll be watching very, very closely what happens when schools start to reopen.
Cassandra at Channel 4 was asking about the medical exemption cards. What's that all about?
Yeah, so there's this completely bogus thing that supposedly comes out from as a part of the American Disability that people are carrying around these cards that say it's a medical exemption from wearing a mask. They're bogus. We actually talked about them at the university. We will not honor them because there is no official exemption card out there. Even if you've had the infection, we can't guarantee that you're immune from this disease, so we're still going to require you to wear a mask. Think about our healthcare workers here at OU Medicine. If somebody gets the infection and recovers, we still require them to wear all the personal protective equipment because we can't guarantee that they're immune.
Okay. Let's see, do you think another shelter in place is headed our way, or that would be a good idea?
Well, I would say in general, if we all took personal responsibility, wore a mask, did the physical distancing, and tried to avoid crowds, I think we could stem the tide of this without going back to complete lockdowns that we had before. I think what you're seeing in some areas of the country, they're doing targeted shutdowns like bars and restaurants where we know there's person-to-person transmission. And just think about it. When you go to a bar or restaurant, you have to take your mask off. That's part of eating or drinking. And so it's very, very difficult to keep you from inhaling respiratory droplets. So I think to see some targeted shutdowns, recommendations, you know, I think any worship service should have some physical distancing and wearing masks just to protect the people that are around you. But I think if we can get most people wearing masks, as the CDC Director Robert Redfield or as the Surgeon General Jerome Adams said this past week, we can start to control this epidemic.
Okay. Russell at KRMG Radio in Tulsa is asking about that we're focusing on fatalities, but not talking as much about maybe chronic long-term conditions that might be in somebody who's recovered.
Yeah, so that's a very good question about what are the long-term consequences of this virus. So the good news, at least at this point, from the best of our knowledge, is most people fully recover. In fact, a lot of people don't even know they're sick and never seek medical care. So that's the good news. There are those people, though, that get quite ill with this disease who have chronic problems with their breathing. Remember, blood clots are a common complication, particularly when those patients are sick enough to be in the hospital, and that can cause blood clots that go to the lung. That can cause strokes, heart attacks, things like that. We know now that a lot of people with the virus do get some heart involvement. Even if they don't have any blockage in their arteries, the muscle gets inflamed from the virus. And in fact, sports leagues have had to address that very, very carefully before they bring, you know, conditioned athletes back to work if they've had COVID-19, because they want to make sure that their heart is healthy before they do that. So I don't think we know yet what the long-term consequences of this particular infection are going to be. I've heard specifically patients who have had long-term headaches. I've heard of patients who have had difficulty breathing, even though they've recovered. It's very, very slow getting their respiratory capacity back. Of course, we've seen the stories of those patients that were in hospitals for long periods of time on the ventilator, and they have to relearn how to work and go to physical therapy and other things to rebuild their strength. So there are substantial long-term implications of this virus.
Okay, trying to get you through these. We've got lots today. Phil at Fox 23 wanted to talk about kids and the spread of COVID. Do they have some sort of natural protection, like fewer ACE2 expressions, and can they transmit the virus to adults?
Yeah, so it's a great question. So can kids get the infection? The answer is definitely yes, and it's been confirmed in young kids in Oklahoma. Kids don't seem to get infected as often, and it may be because they don't have as many of the receptors in the upper respiratory system and the lungs to which the virus attaches. Once you get to about age 10 to 15, though, all that is over, and that age group of children do get infected. Studies from China early in this pandemic showed that when kids, not as many kids got infected, but those that did tend to shed a lot of virus. And they also had a lot of social contacts. And so they can spread it not only within their school, but they can definitely spread it to their parents. So you may have seen the Oklahoma City County Health Department yesterday noted that daycares now are a risk factor, and it's the workers in those daycare centers that are coming up with the symptoms. The kids typically do okay, so it's the parents or the workers in the daycare who may get infected by those kids.
Okay, the governor said he was not contagious 48 hours before he started experiencing COVID-19 symptoms. This reporter is curious if there's science to back that up.
Well, here's what we know is that typically anywhere 48 to 72 hours before a person who's been infected with the COVID-19 virus will start shedding virus. So, sometimes it's a bit difficult to define when the start of symptoms actually occurred, but usually for 2 to 3 days before somebody develops symptoms, they may be shedding the virus and could be infectious.
Okay, Tulsa World, let's see, sorry. Here we go. The state's criteria, I haven't had a chance, these are brand new. The state's criteria for moving a county to red high risk on its COVID alert system require not only a county to have more than 14.39 cases per 100,000, but also the state has less than 5% ICU beds, less than 5% medical surgery beds, less than 5% of ventilators, or fewer than 5 days of PPE. Can you talk about whether that combination of criteria is appropriate?
Yeah, so I've had many conversations with both the State Medical Association and the Oklahoma Hospital Association. I think the system is not helpful at all at this point. If you look at most of Oklahoma, it's all the same color. It doesn't tell you much of anything, and yet we know that there are real hot spots in the state. It looks at the entire state's capacity of medical surgical beds and ICU beds, and honestly, I don't think we're going to transfer patients from an academic medical center of St. Francis in Tulsa out to some small rural hospital because they have a med-surg bed available. I think it's just unrealistic. And so I know the Hospital Association, the State Medical Association are pushing for more regional focus to look at what bed capacity is in the region that you're actually looking at and the availability of supplies. The other thing is 14.43, I think, is the number per 100,000 population. I'm sure that was based on some statistical evaluation, but we know there are many, many counties now that have that level of numbers now. In Oklahoma, there are a lot of counties that don't have 100,000 people. So if you look at that map, there's a whole lot that just have no data at all. So I just don't think it's terribly helpful at this point. I think it could be refined, though, and be much better.
Okay, I think this might be the last one. Can you give us anything positive? Looking forward, are we going to be okay? Are we going to get through this? What's kind of...
Yeah, absolutely. So the positive things here is I think, the real change that will allow us to potentially get back to where life used to be, the normal that we used to be aware of, will be when we have a vaccine available. We don't have to get 100% of the population vaccinated, but we'll need to get a substantial proportion of the population vaccinated to stop the spread of the virus. At that point, then we can start thinking about, do we really need masks anymore? Do we need to physically distance? Can we go back to the business that we, the life as we used to know it? So I'm actually encouraged. I know the vaccines are being tested now. The beauty of this particular pandemic is the government has put a pile of money into those companies to tell them to go ahead and build the manufacturing capacity now, even though we don't even know if your vaccine works yet. Because if it does work and it's safe, they're going to be able to start producing vaccine very, very quickly. So I think that's the good news. For the time being, though, we got to do the best we can. Wear your mask, physically distance, do hand hygiene, try to avoid crowds, and that's what will help us slow it down for now.